Welcome. In this lecture, we'll be discussing muscular dystrophies. Let's first discuss Duchenne's and Becker's muscular dystrophy, as these are the two most commonly tested on exam day. Both of these are caused by an X-linked recessive mutation in the DMD gene, leading to an absence of dystrophin. This is a protein that stabilizes muscle cell membranes, and without it, muscle fibers are easily damaged during contraction, causing cycles of degeneration and regeneration. Over time, the muscle is replaced by fat and fibrotic tissue. This leads to weakness, calf pseudohypertrophy, and involvement of other organs, such as the cardiac system, skeletal system, and even neuronal tissue. Now, Duchenne's is caused from a frameshift mutation, which leads to a complete loss of the dystrophin protein. On the other hand, Becker's is caused from a non-frameshift mutation, and this only leads to a partial loss of dystrophin. The way that I like to remember this is that Duchenne is deleted, meaning that there is nothing left, while Becker is broken, that there is some functionality left. And this is important when we discuss presentation and onset of symptoms. The key points for these two is that because it is X-linked recessive, it classically only affects males. And on exam day, it'll typically be some sort of male child or male teen. The onset of symptoms is typically seen more aggressively in Duchenne's because of the complete loss of dystrophin. This will typically be an individual less than 5. Usually the peak age is between 2 to 3 years of age, where Becker's is between 5 to 15, or more commonly between 10 to 15, or in adolescence of some kind. And this is because of some partial retaining of dystrophin. And the way that I like to remember this is that Becker is better. These individuals typically have a better outcome. Duchenne has a very poor outcome, with a shorter life expectancy, and wheelchair bound by the age of 20. Becker's typically has a better outcome, and these individuals will not be wheelchair bound until later in life. Now let's talk about how these two classically present. We've already talked about the onset of symptoms. Duchenne's typically less than 5 years of age. Becker's is 10 to 15. Because of the complete loss of dystrophin protein, the symptoms are more rapid in Duchenne's. And we'll first discuss the presentation of Duchenne's and then compare that to Becker's. This is typically a progressive, severe muscle weakness, typically affecting the proximal lower extremities. And this is because this is where your larger muscles, like your hamstrings and your quadriceps, sit. This leads to individuals at a very young age, typically around 5, barely being able to walk, go upstairs, or even rise from a seat. This can also lead to waddling gait due to the inability to lead to contractions of the hamstrings and quadriceps. This leads to inability of taking steps forward. Thus, they need to swing their legs out wide in order to move. You may also see a unique sign known as Gower's sign. This is an image depicting what Gower's sign is. This will lead to an individual spreading their legs open and using their upper extremities, their hands and their arms, in order to rise to a standing position. And this has to do with the weakness in the proximal lower extremities. You may also see calf pseudohypertrophy, an enlarged calf muscle not due to enlargement of the muscle, but this is due to deposition of fat and other connective tissue in those areas. You also may see lumbar lordosis, as well as diminished reflexes in a younger individual, typically because dystrophin affects nerves. You may also see, but do not have to see, intellectual disability. And this is important when we compare this to Becker's. Now, all of these symptoms that we've talked about will be very similar to Becker's, but this will be more rapid in progression, more severe symptoms, and will typically take place in a younger individual. On the other hand, Becker's, as we know, typically presents in individuals 10 to 15, and the symptoms will be more slow. What we may see will be mild muscle weakness in the proximal lower extremities, and we can get all the same symptoms that we see in Duchenne's, but typically we see it in older individuals, 20, 25, 30 years of age. You can also have Gower's sign, calf pseudohypertrophy, lumbar lordosis, and diminished reflexes. But again, this will be slower in onset and will typically not affect an individual till they're older in their years. Now, something that is important is that as Duchenne's can have intellectual disability, although they do not have to, in Becker's, you will almost never have intellectual disability. You typically have a normal IQ quotient. Now, how do we diagnose Duchenne's and Becker's? Well, it's stepwise. The first step is always to get creatine kinase. This is caused, or an enzyme that we look at, due to breakdown of muscle tissue. Now, this is a very highly sensitive exam and is used to screen for patients. If this comes back negative, we can almost rule out these muscular dystrophies. Generally, this will be 10 to 100 times higher than normal. We expect a value above 10,000, where your normal is almost 100. If this comes back positive and you have a high clinical suspicion for these diseases, the next step will be your gold standard diagnosis, which is genetic studies. Remember, Duchenne leads to a frame shift, complete loss of the dystrophin protein, where Becker leads to a non-frame shift, only partial loss. If and only if is the genetic studies come back negative, do you ever pursue a muscle biopsy? And the reason being is because this is uncomfortable and painful for the patient, while genetic studies can do the exact same thing without causing so much discomfort. Thus, muscle biopsy is only done if the genetic studies are negative and we have a high clinical suspicion. And what we will see is a replacement of this muscle with fat and connective tissue. So here we have a normal muscle. And on this right side, where we have Duchenne's muscular dystrophy, we see all these circles here are muscle fibers, but we see a lot of white between them. And that white is fat or even connective tissue, which is what is going on in these pathologies, which causes calf pseudohypertrophy and all the other complications that we are going to talk about. Now, both of these treatments are typically multidisciplinary. The first line is always steroids, and this is thought to slow down the muscle breakdown. It's an anti-inflammatory. We can typically give something like prednisone. You want to start these individuals on physical therapy. This prevents contractures as well as strengthens the muscles that we are using. And you also want to monitor for complications. Now, there's a large multitude of complications, but the two that you want to know for exam day are the two most common causes of death. And this will be respiratory failure and dilated cardiomyopathy. Now, in both Duchenne's and Becker's muscular dystrophy, we have a loss or an abnormality number of dystrophin gene. And this weakens skeletal, cardiac, and respiratory muscles. This causes a weak diaphragm and intercostal muscles, which leads to restrictive lung disease and can also lead to respiratory failure. While also the dystrophin loss in the heart muscle causes myocyte damage, fibrosis, and dilated cardiomyopathy over time. Now, because we have the dilated cardiomyopathy, this can also lead to arrhythmias in both Becker as well as Duchenne, and this mostly leads to heart block. Now, please also know that more common than not in Duchenne's than in Becker's, you may also be linked to scoliosis, which is more commonly thought to be linked to younger individuals. Now, let's talk about myotonic dystrophy. This is caused from a trinucleotide expansion of the CTG repeats, which is found on the DMPK gene on chromosome 19. Now, this leads to splicing, and what is thought to happen is that we have these expanded repeats, these CTG repeats, which cause a toxic gain of function RNA. And what this causes is trapping of the RNA binding proteins. And this disrupts alternative splicing in multiple genes. This causes a lot of symptoms in the long run. Now, myotonic dystrophy compared to the other two, Becker's and Duchenne, is autosomal dominant, not X-linked recessive. And this is thought to be linked to anticipation, very similar to how Huntington's is caused. Thus, this is worsened in successive generations. Essentially, the longer the repeat length, the longer the CTG repeats, the worse the symptoms. And this all has to go back to the splicing that we see in multiple genes. The longer it is, the more splicing that happens, the more genes are affected. Now, myotonic dystrophy has a very unique presentation. Now, like Becker, it typically presents older in life. 12 to 30, 20 to 30, you'll see different age cutoffs used. This can cause facial weakness, dysphagia. One of the hallmarks of myotonic dystrophy and how it got its name is hand grip myotonia. And this is delayed relaxation of the muscle after a voluntary contraction. For example, if a patient makes a fist, they have very difficulty quickly opening their hand again. And that's the key trait there. Quickly opening their hand. If you were to have them slowly do it, you may not be able to see it. But if you ask them to quickly open their hand, you may see issues. Now, also compared to Duchenne's and Becker's, we typically see distal weakness of muscles comparatively to proximal. So it's the opposite of what we classically seen. You can also have other comorbidities, cataracts, hair loss, testicular atrophy, or even infertility. The way that I like to remember these comorbidities is with the mnemonic CTG. Remember, that's our trinucleotide expansion here. C stands for cataracts, T stands for toupee or balding or hair loss, and G stands for gonadal hypertrophy. So testicular atrophy, which can in turn lead to infertility. So these three are the very, very common other symptoms that we may see, plus the hand grip myotonia and the distal muscle weakness. Now, diagnosis is very similar to the previous two, but a little bit different. Now, the creatinine kinase we can start with, but this is usually normal and only maybe slightly elevated, and is thus not very helpful. If we're thinking myotonic dystrophy, the best screening test is actually an EMG, as this has a high sensitivity. And what you may see here is bursts, and we see waxing and waning amplitude and frequency. But what you need to know is the sounds that we may have on exam day. Dive bomber or even revving motorcycle is sometimes depictive terms of the sounds from EMG about their muscle usage. Again, the gold standard diagnosis, as in the next step, will be genetic studies. And what we're looking for there is the CTG expansion. Only if this comes back negative, again, and the genetic study is inconclusive, then can we get a muscle biopsy. And here what we want to know for the muscle biopsy is we see these rounded fibers, but what we also see is this internal central nuclei. Note please that this is a more increased, highly magnified image than the prior, and we don't see as much white as in the prior, because this is not being deposited with fat or any connective tissue. But what we do see are these little specks right here. And these little specks are not on the outside or the periphery of the nerve where they're supposed to be, but instead these are nuclei that are located in the center of these muscles. And that is very commonly seen in myotonic dystrophy muscle biopsy. Now the treatment, similar to the prior ones, is also going to be supportive. PT, muscle relaxers, pain meds. You can use a medication known as mexiletine, which is a sodium channel blocker, which is used to decrease myotonia. This is typically done if it's causing symptoms or causing issues at work or at home. And of course, we also want ophthalmology to assess for cataracts and other complications. Myotonic dystrophy is also linked to very similar complications that we've already talked about. Respiratory failure, dilated cardiomyopathy. These are rarer than Duchenne's and rarer than Becker's. But something else that you want to know is that myotonic dystrophy, because it is linked to the CTG repeats, can lead to diabetes because it affects the endocrine system. As always, here is a table summarizing these three diseases. And that concludes this lecture on muscular dystrophies.